I welcome Dr. Ronan Mckenna, who has a background of pediatrics in UK, and he has recently completed his training in pediatric ICU in Australia and is employed at the ICU at Gold Coast University Hospital, and he's presenting his paper on pediatric intensive care admissions during 2015 and 16 Queensland human Parechovirus outbreak. Welcome, Dr. Mckenna.
Hi, thank you. Good afternoon, everybody. Thanks for the opportunity for me to present the findings of this study that we did into intensive care admissions during a human Parechovirus outbreak that we had up in Queensland. And what I want to do is I want to highlight maybe 4 implications that I've taken away from the study that I think will be important to us as critical care providers when we're confronted with what we will have, future outbreaks of human Parechovirus. And these are namely that it's a severe disease. Some of these children had multi-organ failure, were on multi-organ support, and most worryingly had evidence of acute brain injury. The other thing to highlight is tachycardia in these children. So it was common, and it does not always indicate hypovolemia and the reflex action to give fluid bolus therapies. The other thing that I think is important is that we may be under-recognizing seizures in these children. And then also that we don't really know which children are at risk of the acute brain injury that can certainly occur. So just briefly, a quick overview of human Parechovirus. So it's an RNA virus, a member of the Parechovirus family. And there are 19 genotypes and counting. Human Parechovirus type 3 was first reported as causing disease in children in a Japanese infant with flaccid paralysis in 2004. But then, since then, it has emerged pretty much worldwide, and there have been case series and case reports from around the world, including a large series from New South Wales in the early 2010s. In all of these series, or in a lot of these series, some of the children require ICU management. But the actual details of what management they received is varied and is limited. So what I wanted to do was to have a look at how we managed the children that ended up in ICU. And so it's a retrospective study. We had retrospective chart review, interrogation of our databases, and we identified all the children admitted to the 3 Queensland ICUs, children's ICUs, with laboratory-proven human Parechovirus infection. And I collected demographic data, clinical data, and specific PICU-related metrics. So that included percent predicted mortality using PIM3, duration and need for organ support, as well as I worked out which children fulfilled sepsis criteria and organ dysfunction criteria using the guidelines from 2005 International Paediatric Sepsis Conference. These are the children that we found. So there were 30. Most of them were neonates, and all of them were under 3 months of age. All of them had human Parechovirus 3 identified, and in all but one that was identified in the CSF. The one child that wasn't identified in the CSF, it was on a nasopharyngeal aspirate, and that kid was felt to be too sick to have an LP performed. Percent predicted mortality of the whole cohort was low, 1.79. This is just a graph showing the admissions and the sort of you can see the light blue is the hospital admissions, dark blue is the ICU admissions, and they sort of follow the hospital admissions. And they peaked at around 2 admissions a week in November, December 2005. The children requiring admission to ICU. There's about 16% of the whole children with positive HPV laboratory confirmation. And the children who ended up in ICU were significantly younger than the ones who just were admitted to hospital. So ICU kids had a median age of 20 days. The hospital admissions were a median age of 41 days. So how sick were they? They were pretty sick, or some of them at least were pretty sick. So over a third were ventilated, and they were ventilated for over 2.5 days, median duration. Just under a quarter required vasoactive infusions, and again, the duration was over 2 days. And they needed relatively large doses, as reflected by the high vasoactive inotrope score. 4 of them required blood product transfusion. 2 of them required a laparotomy. Most worrying, in my view, is 9 of them had abnormal MRI scans of the brain. The PICU length of stay was 2.62 days. During the study period, I think within our ICUs, the median length of stay is about 1.8 days during that time. When we look at the sepsis criteria and organ dysfunction criteria, again, this just reflects that some of them were pretty sick. We had severe sepsis in nearly half of them, and nearly half of them had multiple organ dysfunction. The most common organ dysfunctions were the neurological system and respiratory system. So that's the first point. Some of these children could be very unwell and take up a little bit of our time. The next point I want to make is about the children with tachycardia. So lots of these children had tachycardia. We use tachycardia, and our sepsis guidelines use tachycardia as a trigger for fluid resuscitation. And that's fair enough, knowing that within sepsis, there may be a component of hypovolemia within the pathophysiology. Not surprisingly, lots of our children got fluid bolus therapy. What is surprising is that they didn't all get it, and I have a theory about that. But most of them got fluid and got lots of fluid, so 50 mils per kilo was the median. But then what did it do? In 2 cases, the hypotension that was present in 9 resolved, but in only 1 case did the tachycardia resolve. And so we saw that after fluid loading, we still had tachycardia in 50% of the whole cohort. And that remained, even though they were fluid load, the fever had melted away, and they didn't have hypotension. So this would suggest to me that there's a different mechanism driving the tachycardia. And as it may be, as we know that most of these children had CNS infection, where there's a central mechanism driving it. So pain, agitation, or maybe even seizures. Which brings me on to the next point, is my feeling that maybe seizures were under-recognized in the group as a whole. So seizures were clinically diagnosed in 40% of the group, but only 5 of those children received actually any specific therapy, and only 3 of them had EEG performed. And in 2 of those EEGs showed subclinical seizures. So we know that seizures can be difficult to diagnose in these children. They were infants and neonates. A lot of them were apneic. Maybe apnea was a seizure. And maybe other children had subclinical seizures that weren't recognized. So that, I think, is definitely important in terms of our understanding of the disease natural history. But it may be important as to whether unrecognized seizures and uncontrolled seizures have an effect on the acute brain injury that you see. Which leads me on to the acute brain injury. So 11 of the whole cohort had an MRI performed, and 9 of those were abnormal. And they had fairly typical abnormalities, white matter abnormalities that have been described before. But not everybody got an MR. The decision to do an MR was clinician-based, and it was kind of skewed to the sicker patients. So the ones who were on ventilator, the ones who were on inotropes, ones who had difficult to control seizures got the imaging. And the majority of the imaging was abnormal. There was, however, 2 children who had MR performed, which was abnormal, and they were neither ventilated or on vasoactive infusions. So to me, that suggests that maybe we're missing some patients, and that you can get evidence of acute brain injury without actually needing the organ support. So just to go over that and summarize the implications for the future, When we're confronted with a HPV outbreak again, which we may be around the country, we should expect that we're going to have some pretty sick children coming our way. Even if we've not got an outbreak going on, if we're presented with a pretty sick neonate, young infant, we should include human parechovirus 3 as part of the differential diagnosis. If these children are tachycardic and we know we're in an outbreak of HPV3, we shouldn't reflexly jump for fluid bolus therapy. I think we should be looking harder for seizure activity. And I think we should be scanning more kids. And, as a start, if the child ends up in ICU, I think we should get an MR of the brain. Thank you.
The audience, Ben? Mic. Use the mic.
We know that children who have severe septic shock often have neurological or MRI neuroimaging findings that are abnormal, but what percentage or proportion of this cohort had long-term follow-up or any prolonged neurological problems?
So as part of it, there is an ongoing surveillance and there's been attempts to follow up the children as much as possible. And that is in print, or in press, but not published yet. And so of those 9 children with abnormal MRs, 7 of them have developmental impairment, which can range from spastic quadriplegia, sort of pretty severe motor deficits in 5 of them, and some speech delay in two others. It's not clear, and I haven't been able to find out whether the 2 that aren't, whether the 2 that weren't on organ support at the time.
Simon, at the back.
Thanks, Ronan. One of the things we found, we had a few babies and they had this bizarre sort of discoloration in their
Mad syndrome, isn't it?
like some sort of
Not so much that, but they all had this sort of rash that sort of classically, a lot of them had that red rash, so you thought, oh, is this, staph sepsis or something, or staph skin infection? But not so much a perfusion problem. We did echo all the children who ended up on inotropes, and function was normal, structure was normal. With the rash, so what we found as we got used to these kids coming in, and I think this is why they didn't all get fluid boluses, as people got more comfortable with making the diagnosis on clinically, they were more comfortable in not giving fluid therapy and just observing the kid with a heart rate of 200.
Johnny?
Okay. Yep. It is. Yeah, so I don't know why the GI is affected so much, but it is, and it's often prominent. I think in ours it was about 45% had distension. The 2 who had laparotomy had severe distension, tender abdomens, enough to go for laparotomies. One of the cases had torsion of the small bowel. Another of the cases had macroscopic pancreatitis, so saponification, but no evidence of biochemical evidence of pancreatitis. So it is pretty common. So most of the children will have some. You'll think, oh, that belly's a little distended. I don't quite know why. Some of the other parechovirus, so 1 and 2 are probably more common than 3, and they will often cause a mild gastrointestinal illness. So. I'm not sure whether there's actually sort of a gastrotropic effect.
Just one more question. In your 30 cases and others who presented to the hospital, what point in time the diagnosis was made, and whether it changed the directions of hemodynamic support or vasoactive agents when it was made? Was there any signal on that?
So the diagnosis would depend on, surprised at how sick. We had LPs on pretty sick kiddies, so they were often done before they came to us, and then the kid was a whole lot sicker. But so that gave us the lab diagnosis. as we got used to the patients coming through, you were making a clinical diagnosis sooner. Changing the therapies, once we got the diagnosis, we maybe stopped the antibiotics. All of them were on broad-spectrum antibiotics. The kids who ended up on vasoactives, that was pretty obvious early on. So they were tachycardic and hypotensive early on.
Yeah.
In the majority of cases, there was one case where that wasn't the case. True.
Is it possible to diagnose it by any other means other than LP, like blood PCR or?
So it is. So the test that they did was a reverse transcriptase PCR.
Yeah.
That can be done on CSF. It can be done on blood. It can be done on MPA, and it can be done on stool. The problem with doing it on the stool is that having a positive stool doesn't mean acute infection. You can still have that positive for several weeks
Shedding.
afterwards.
Yeah.
Thank you, Dr. McKenna. That was excellent.